Good morning, everyone. I'm delighted to introduce our speaker today, Dr. Cynthia Nast from Cedar Sinai. She's professor at UCLA, double titled, yeah. And she's past the president of Renal Pathology Society. She's also co-chair of Pathology Committee for Leptin and Jion research projects. And she's on associate editor, chronic kidney disease, multiple journals. So we are so happy to have here today. And her topic is on classification and pathology of C3 glomerulonephritis thrombotic microangiopathy. Welcome, Dr. Nast.
Thank you for having me this morning. It's 6 a.m. my time, so if I'm a little bleary, you can forgive me. So we're going to start by talking about membranous-proliferative glomerulonephritis, or MPGM, which is a lesion that is identified in 2% to 10% of glomerulonephritis on kidney biopsy. And it's usually secondary, although really it's probably always a secondary lesion. We're just not smart enough to know what the underlying antigen is in some of the cases, particularly in children. And it is a pattern of injury. It is not a diagnosis. It is just a lesion, a particular pattern that glomeruli have when they're injured in certain settings. And it's characterized by an increase in mesangial cells and matrix, a lobular pattern to the glomerular tufts, capillary wall double contours due to mesangial interposition, which I'll show you in a moment, endocapillary or capillary luminal hypercellularity, which is probably a mix of inflammatory cells and swollen endothelial cells, subendothelial electron-dense deposits, and then there may also be mesangial, subepithelial, or intramembranous deposits. So looking at this a little more closely, because this is a pathology conference, there's this lobular pattern to the tufts, so this lobular accentuation, with here a lot of endocapillary hypercellularity, or too many cells in the capillary lumens, as well as mesangial hypercellularity. A normal mesangial region should have no more than 3 mesangial cell nuclei. And there's clearly many more than 3 nuclei in here, as well as some increase in matrix. This is a Jones silver stain, so matrix stains black on the Jones stain. And over here are capillary wall double contours, again highlighted in black with the Jones silver stain. And these capillary wall double contours occur because mesangial cells send out pseudopods called mesangial interposition, here on the subendothelial side, which is between the basement membrane and the endothelial cell. And they send this out because there are subendothelial electron-dense deposits. So the mesangial cell sends out a pseudopod, and then the mesangial cell and the endothelial cell together make new basement membrane mesangial matrix material, forming a second layer or contour, thus giving that double contoured appearance to the capillary walls. And in MPGM, not only are there subendothelial deposits, here again with mesangial interposition and a double contour, but there may also be subepithelial deposits and mesangial deposits, as are present over here. So if we look at the historical classification of MPGM, it was based on the patterns by light microscopy and electron microscopy. And it was divided into 3 types, type 1, 2, and 3. Type 2 is dense deposit disease, and it's really not lobular. And the deposits are intramembranous, causing an electron-dense transformation of basement membrane and mesangial matrix material. And it never should have been included in MPGM to begin with, frankly. Type 1 and type 3 both have double contoured capillary walls, this lobular appearance, and subendothelial deposits. And in type 3, there also are subepithelial and intramembranous deposits. And it was thought about, MPGM was classified this way for many, many, many years. The problem is that if you look at the immunofluorescence, Dense deposit disease is always a C3 dominant or C3 only immunofluorescence in the electron dense deposits. Type 1 may have C3 only or may have C3 with immunoglobulins and or C1q. And type 3 also may be C3 only or include immunoglobulins and or C1q. So this didn't really make a lot of sense from a pathogenetic point of view. So if you pull these out and you look at it by what is actually in these electron dense deposits, these were pulled out and then reclassified as C3 glomerulopathy, looking at it from the point of view of what's actually in there, and maybe that relates to the pathogenesis of how it came to be in there, as opposed to just a pattern of injury, which is nonspecific. And C3 glomerulopathy encompasses C3 glomerulonephritis and dense deposit disease, whereas those that have immunoglobulin and or C1q were then classified as immune complex type NPGM, which can have a type 1 or a type 3 pattern, and that actually really doesn't even matter. So the current classification is by immunofluorescence, which is thought to reflect pathogenesis. And if we look at, again, NPGM, those that are dominant C3 are thought to be mediated by complement and include dense deposit disease and C3GN. Those that have immunoglobulin are secondary, and due to infection like hepatitis, autoimmune disease, hematologic disorders, certain types of paraprotein-driven lesions, and malignancy. So these are the underlying lesions we see with immune complex NPGM, although again, in some of them we really don't know what the underlying antigen is. And then there are non-immune complex, non-complement mediated NPGM pattern glomerular lesions due to endothelial injury, such as thrombotic microangiopathy. So this is part of where C3GN and thrombotic microangiopathy overlap, although they overlap in other ways as well. So looking at C3 glomerulopathy, when we look at glomeruli and we look at them by immunofluorescence, there can be a dominant C3 in these electron-dense deposits. And post-infectious glomerulonephritis or infection-related GN is a dominant C3 lesion. Sometimes there are others, like when an immune complex lesion is resolving, the C3 may be left behind and the other things may disappear first, like IgG or C1q. But C3 glomerulopathy is another variant of these C3, the glomerulonephritis with dominant C3. And again, this includes DDD and C3GN, which are related to mutations and autoantibodies. And these are in the complement pathway. So the current concepts are that there's immunoglobulin and complement involvement with different, but sometimes overlapping pathogenic mechanisms, which I'll show you, and they involve the complement cascade with abnormalities of regulatory genes, autoantibodies, and there are some gene mutations in non-complement proteins, genes that code for non-complement proteins like DGK epsilon and thrombomodulin that have more to do with the clotting cascade, not complement, but there's an overlap there. So we have to talk for a minute about complement, and I will try to make this not too boring or annoying. So we have the three pathways: classical, lectin, and alternative. And when you have a C3 lesion with no C1q and no immunoglobulin, that indicates there's alternative complement pathway involvement, because classical is C1q and lectin involves C4 and C2, which is also in classical. So if we don't have C1 or C4, then we're in the alternative complement pathway. And you have a tick-over or normal, spontaneous, low-level activation of C3 going on all the time. And this is to create C3b, which then goes and sits on all kinds of cells all over the place and is normally degraded. And this primes you, so if you get an infection, it can start activating and attacking. And so we always are making some C3b, and this is regulated by factor I and factor H, it downregulates it, whereas factor B and factor D upregulate it. And then if it continues to be augmented, you get combining with B when it splits. So you get C3B combining with BB, and that is your C3 convertase. So this is the activation of the alternative complement pathway. And you just have to know that factor I and factor H augment it, or are blockers, regulatory blockers, and factor B and factor D augment it, and C3 convertase is required for the continued activation and making your membrane attack complex. So alternative complement pathway, factor I and factor H, damp it down, factor B and factor D upregulate it, and C3 convertase is required for full activation of the complement pathway. So why do we have dysregulation of the alternative complement pathway? Well, there can be autoantibodies, particularly against factor H. So if you have factor H and it's blocked by an antibody, it's not going to work. And so you don't have downregulation of that normal tickover of C3. C3 nephritic factor is an autoantibody against C3 convertase, but it actually stabilizes C3 convertase. So if you look at them, if you have an autoantibody against factor H and damps it down, you're going to have a loss of function of factor H, and you're going to have augmentation of complement activation. But if you have C3 nephritic factor, which stabilizes the C3 convertase, it will become more active, and you'll have a gain of function. And so if you look at mutations in complement regulatory genes, you have the same thing going on. If you have mutations in factor H-related proteins, factor I, membrane cofactor protein, which is CD46, these are downregulators. So if you have mutation and loss of function, you'll have augmentation of the complement pathway. And then if you have C3 convertase upregulation or factor B upregulation, you get this gain of function problem. And so you have continued activation. So mutations here cause gain of function, mutations here cause loss of function. And they all end up with augmentation of alternative complement pathway regulation. And then other genes such as thrombomodulin and DGK epsilon also can impact complement regulation. Is that clear? Kind of. So this is an alternative complement pathway process. But what about the classical or leptin pathway? And there was a very interesting paper published last year by Zhang looking at C4 nephritic factors. So C3 nephritic factor stabilizes the C3 convertase, which is in the alternative complement pathway. C4 nephritic factor, and that's over here. C4 nephritic factor stabilizes the C4 convertase. The C4 convertase does the same thing. It activates C3, but it's through the classical or leptin, mannose-binding leptin pathways, which involve C2 and C4. And they found that the C4 nephritic factor would stabilize the C3 convertase through the classical and the leptin pathways, resulting in augmentation. And they found this associated with C3GN and dense deposit disease, but without the C3 neph or the C3 convertase stabilizer, suggesting that there is a role for the classical and the leptin binding complement pathways in C3GN and dense deposit disease, not just the alternative complement pathway. So this is more complicated than we think, as everything always is. But the majority of these lesions result from dysregulation of the alternative complement pathway with glomerular deposition of C3. So the bottom line is something's wrong with the alternative complement pathway. So how do we get there? Well, C3 is in the fluid phase when it's involved in C3 glomerulopathy. And there's the C3 tickover with this constant production at low levels of C3b, which is increased when there's dysregulation of the complement pathway. And what happens is the C3b binds with circulating proteins to form C3b protein complexes. These complexes are broken down by factor H and factor I. So if these factors are not working, you have a buildup of these C3b protein complexes. And these can deposit in glomeruli. And this is probably what those electron-dense deposits are, because they're not immune complexes. There's no immunoglobulin in there. And we've always wondered, what is this stuff? How does it get there? And so they are complexes between C3b and proteins that deposit, and that's why all we see is the C3, or most of what we see is C3. And there was a very nice study done, published in the Journal of Immunology in 2014, where they took patient sera from patients with a dense deposit disease and C3 glomerulonephritis, and looked for these C3b protein complexes, and they found them in 87% of the patients with dense deposit disease and 50% of the patients with C3GN, and they were associated with C3 nephritic factor, so associated with dysregulation of the alternative complement pathway. So this doesn't explain all of the electron-dense deposits we see in every patient with these abnormalities, but certainly explains a lot of them. So this is one of the ways the electron-dense deposits get in glomeruli and cause C3GN. So looking at C3GN, it's very rare, 1 to 2 cases per million people per year. 30% are in children. About half have a low C3 with a normal C4, again, the alternative complement pathway, not the classical. A little under half will have C3 nephritic factor, or that C3 convertase stabilizer. A little over half will have a C5 nephritic factor, stabilizing the C5 convertase, so augmenting development of the membrane attack complex. And there are features that can overlap with dense deposit disease and with infection-related glomerulonephritis, with variable clinical presentations. And the clinical presentations correlate with the glomerular lesions that we see in C3GN. So how do we define C3GN? Well, it's defined by having electron-dense deposits which contain C3 at least 2 orders of magnitude greater than any other immunoglobulin or immune reactant. So if you have 1 plus IgG in the deposits, you have to have at least 3 plus C3. So if you have trace IgG, you can have 2 to 3 plus or 2.5 plus C3. So it has to be at least 2 orders of magnitude greater. There are subendothelial deposits, often mesangial deposits, and there may or may not be subepithelial deposits. And interestingly, you can see big hump-shaped deposits as are typical for post-infectious GN. And there are 4 different glomerular patterns of injury. The majority are NPGM, which is how we got there in the first place. There can also be a mesangial proliferative GN, a diffuse endocapillary or exudative glomerulonephritis, which looks by light microscopy for all the world like a post-infectious or infection-related GN. And then a small number will present as crescentic GN. And these are all patterns of injury by light microscopy. So here's the NPGM pattern. And it has this typical lobular or nodular accentuation of the tufts with capillary double contours. This is a Jones silver stain. Note that in the mesangial regions, instead of being black, it's got this pink, or it's silver negative. And C3 deposits often will be silver negative. So if you see that, then you have to think of this. Other things that can be silver negative are amyloid or fibrillary glomerulonephritis. So there's a differential diagnosis. But when you see that, it's something that you need to think about in the differential. Obviously, C3 brightly staining in the mesangial regions and along capillary walls. And by EM, the mesangial regions are here sort of replaced by this electron-dense material, these electron-dense deposits, which in C3GN are often sort of ill-defined and amorphous. There are not clear borders between the deposits and the mesangial matrix. Not always, but often it's sort of this sort of merges. Here's electron-dense material, and it's kind of merging here with this paler matrix next to it. And then subendothelial deposits, mesangial interposition, new subendothelial basement membrane mesangial matrix material, here also filled with deposit. So this would look like a double contour by light microscopy. The mesangial proliferative pattern looks like mesangial hypercellularity, too many mesangial cell nuclei, more than 3, widened mesangial regions. This is a PAS stain, which it looks like matrix on the PAS stain, so different than the Jones-Silver stain. Notice the capillary walls here are single contoured. By immunofluorescence, the C3 is predominantly in the mesangial regions, not along capillary walls, as with the NPGM pattern. And then these same mesangial, sort of ill-defined electron-dense deposits with very, very rare subendothelial deposits. The exudative pattern really looks like a post-infectious GN, here with many neutrophils occluding the capillary lumens. There's not only mesangial C3, but these sort of irregular, granular sort of dots, which correspond to these subepithelial humps, which can be seen in dense deposit disease, C3GN, and post-infectious GN. So they are not diagnostic for one versus the other. And then these ill-defined, again, mesangial deposits, which can be seen. And then a crescentic pattern where it looks like crescentic GN. There's no mesangial hypercellularity, but by immunofluorescence there is C3, and you see these deposits, again, in the mesangial regions by EM. So the clinical presentation obviously varies. If you have a crescentic GN, they're going to present like a rapidly progressive glomerulonephritis. If you have an NPGM, they're probably going to have heavy proteinuria, usually with some hematuria. So the presentation really depends on the morphology. So why do people get C3GN if they have an underlying mutation? Well, there has to be a trigger. So there's activation of the alternative complement pathway due to infection, like strep or staph or viral infection, certain medications, pregnancy can do this, paraproteins, as well as transplant, particularly with antibody-mediated rejection. And what happens is there's activation of complement, the alternative complement pathway, but in these patients they cannot re-regulate their complement. If you look at adult human kidney biopsies, pretty much every single one, if you look hard enough, will have an old, round, resorbed deposit in an intramembranous location or a subepithelial location. We've all had post-infectious GM. But we can re-regulate our complement so we don't get kidney disease. But in these people, because they have an underlying complement abnormality, they cannot re-regulate complement once that alternative pathway has been activated and triggered. And then they go on to develop renal disease. And in fact, what used to be thought of as a typical post-infectious glomerulonephritis is really C3 glomerulonephritis, where it was triggered by an infection and then they couldn't re-regulate. So there's this disease spectrum that occurs. And this is from a case that I actually had back in the early days when we first had identified C3GN as a disease. And this was an older gentleman in his 70s who presented with pneumonia, low C3, and by light microscopy looks like a post-infectious. There's neutrophils within the capillary lumens. There's this coarse granular staining by C3 with some mesangial staining. And you can have different IF staining patterns in post-infectious related to the age of the disease, because as it resolves, you can get mesangial deposits. And by EM, here's a subepithelial deposit at the mesangial notch or waist area, typical for post-infectious. A few more mesangial deposits than we typically see with this active GN, but certainly with that history would fit in with a post-infectious GN. Well, 18 months later, he still had a low C3. It never normalized. He still had evidence of active GN with hematuria, proteinuria. His creatinine had crept up a little bit, and so he was rebiopsied. And at this time, he still has an exudative pattern of his glomeruli. There's even, if anything, more neutrophils than there were before. There's more C3, now in more of a mesangial pattern, And then by EM, this absolutely typical finding of these sort of ill-defined mesangial deposits, still with subepithelial humps. So a beautiful example of how probably an infection triggered a post-infectious GN, which then transformed to C3GN, because this patient couldn't re-regulate his complement. And in fact, he had a factor H mutation. There can be an overlap with dense deposit disease. So here is a biopsy from a patient with C3 glomerulopathy. And in this capillary, there are subendothelial deposits as well as some subepithelial deposits with a normal glomerular basement membrane. But over here, this glomerular basement membrane shows electron-dense transformation, which is the diagnostic lesion in dense deposit disease. So there's not necessarily always just one or the other. There can be overlapping features morphologically. And this could be because there are different mutations. Often a patient will have a mutation in more than one gene, some more related to C3GN, some more related to dense deposit disease. Some patients will have a mutation and an autoantibody. There can be different expressions of a single disorder. It may be due to sampling variability. Maybe when we only see C3GN, it's because we didn't happen to catch the glomerulus that had DBD changes. So there is this overlap. They're not completely clear and distinct, which if you understand that the pathogenesis is related, that's not really too surprising. So what about C3GN and monoclonal proteins? Well, as I mentioned, monoclonal paraproteinemia can be related to or a pathogenetic mechanism for C3GN. Well, kind of and kind of not. So this was a case in an adult with a typical NPGM pattern by light microscopy, C3 by immunofluorescence. By immunofluorescence, there was no IgG. There were no light chains. It was just C3. But in adults, studies from the Mayo Clinic have suggested that C3GN may in fact mask a monoclonal protein-related glomerulonephritis in up to 38%. In our experience, it isn't that high, but it certainly does occur. So what you do is you have to do immunofluorescence on pronase-digested, antigen-retrieved, formalin-fixed paraffin-embedded tissue. So you can do IF on paraffin-embedded tissue if you do an antigen retrieval technique first. And when we did it in this case, we not only found 4+ staining for IgG, but there was kappa without lambda, and when we looked at IgG subclasses, it was restricted to IgG3. So this patient, in fact, had an IgG3 kappa paraprotein, and when they looked, in fact, they found a small plasma cell lesion in the bone marrow. In these patients with a initially identified C3 glomerulonephritis and subsequently found to have a paraprotein, in almost half of them, they will have a C3 nephritic factor. So there is a complement regulatory problem with stabilization of the C3 convertase. And interestingly, the paraprotein in some of these cases has been shown to act as a factor H autoantibody, which would explain why there would be this C3GN lesion in addition to the paraprotein. And the C3 just obviously covers and hides the paraprotein, and so you have to do this antigen retrieval to identify it. And so the bottom line is, when you have C3GN in an adult, you should pretty much always perform IF on the pronase-digested, formalin-fixed, paraffin-embedded tissue to make sure you're not missing a paraprotein. So what about immune complex NPGN and C3GN? And this is immune complex NPGN that's so-called idiopathic. There's no underlying autoimmune disease or malignancy or infection. It's NPGN, and we don't know why the immune complexes are there. So if you look at these patients, there is alternative complement pathway dysregulation in about half, with abnormalities of factor B, factor H, low C3, normal C4 in some of them, even though they have immune complexes, and about half of them will have a C3 nephritic factor. And in fact, immune complex NPGN may be another trigger for C3GN. And C4D does not discriminate. If you look in the literature, some studies say it does, some studies say it doesn't. It's really not consistent at all. And interestingly, these two lesions have similar renal survival. So are these really different diseases? Or is it, again, a spectrum of one disease? Or where is the overlap? And if you look, C3GN in subsequent biopsies can transform to immune complex NPGN and vice versa. It's possible that an immune complex NPGN can can be a trigger for an underlying complement dysregulation, like an infection can. There can be overlap or switching of C3GN, NPGN, and thrombotic microangiopathies, because atypical HUS as a thrombotic microangiopathy is a complement-driven lesion that we'll talk about shortly. And whether it's a fluid phase or a tissue phase, C3 lesion can be involved in this switching, and other host factors can be involved as well. So there was a really interesting study done that was published in JASN this year, looking at a cluster analysis of C3 glomerulopathies, dense deposit disease, C3GN, and immune complex NPGN. And what they did was they looked at these, obviously excluding the known secondary immune complex NPGN. So just looking at those where the pathogenesis was not able to be identified. And they used 34 variables, including parameters from the complement pathway, clinical data, pathologic features, and some genetic variants, because they typed all these patients for the different complement genes. And what they found when they did a cluster analysis using these parameters, the patients fell out into 4 clusters. And then they went back and they used an algorithm to assign the patients to one of the clusters depending on how they presented with these 34 factors, 34 variables. And what they found was that in clusters 1 and clusters 4, you had both C3GN and immune complex NPGN. They did not discriminate. Cluster 2 was mostly immune complex, and cluster 3 was mostly dense deposit disease. But in 2 of these clusters, the immune complex NPGN and the C3GN were not differentiated. And interestingly, in cluster 1, it was a fluid phase dysregulation of the complement pathway, which is associated with C3GN. But in cluster 4, it was not. And cluster 4 had the worst outcome. So what this study does is tell us we really have no idea what's going on, and that we have a lot more work to do. This is a very complex disease process, and it really makes a difference because we need to elucidate the pathogenesis to understand our treatment approaches and our prognosis. So this raises more questions than it answers, but also gives us directions to look at to understand these lesions. So with that, I'm going to switch gears a little bit to the thrombotic microangiopathies. And one of the things that TMAs have in common with NPGN is that they both are just a histologic pattern of injury and not a specific diagnosis. There are several etiologies for thrombotic microangiopathy, and there may be distinct or overlapping presentations. And of course, the treatment, as with all things, depends on the pathogenesis, so we have to understand the pathogenesis. So I'll spend a minute on histopathology, because this is a pathology grand rounds. So the acute features of thrombotic microangiopathy include thrombosis, fragmented red cells, and fibrin in the vessels, endothelial cell swelling, and a mucoid intimal thickening, or edema, if you will, of the vascular wall. In glomeruli, there's thrombosis, fragmented red cells, subendothelial lucencies, there's early mesangiolitis, acute ischemic capillary wall wrinkling, and there may be inflammation and crescents because of damage to the capillary wall because of the thrombotic process. And cortical necrosis can also be seen. So here is an arteriole with marked thickening of the intimal area here, swelling of the endothelial cells, fibrin deposition, an almost absent lumen. Here's a thrombosed artery. Sometimes you don't see fibrin, you just see this mucoid intimal thickening here in this artery. It looks quite different than typical nephrosclerosis, which is just a very dense blue collagen. The endothelial cells are swollen, the lumen is narrowed. If you do immunofluorescence on this, you will actually see fibrin in here. And there can be thrombosis of arterioles and going into glomeruli. Here, this glomerulus has not yet become ischemic. But here, here's a nice thrombus coming into the intraglomerular arteriole with a few thrombosed capillary loops. And here we have early ischemic change with this wrinkling of the capillary walls. Kind of, you're losing the capillary lumen, and it's because of the thrombus in this arteriole. Here's mesangiolisis. Mesangiolisis is where the mesangial matrix literally dissolves. It just literally falls apart due to fibrinolysis, tissue metalloproteinases, and other things that are activated that break down collagens and so on. And you can see here's a normal mesangial region. It's black on the silver stain, and here it just looks like bubbles. You don't even see any matrix anymore. So that's mesangiolisis. We see it in 3 settings: thrombotic microangiopathy, transplant glomerulopathy, which is almost a variant of thrombotic microangiopathy, and in diabetes because of injury from the diabetic milieu. We can see this. And here is our red cells that are broken down. You can see all these fragments of red cells in this glomerulus in a case of thrombotic microangiopathy. So red cell fragmentation is another feature. And then cortical necrosis, where everything is just infarcted and dead. In subacute organizing or chronic thrombotic microangiopathy, there's a little bit different appearance, where the vessels have sclerosis or collagen deposited, but not in a typical thickened fibrotic way of benign nephrosclerosis. There's luminal narrowing, there may be organizing thrombi, and when you get that organizing fibrosis or sclerosis, often it will occur in the circumferential pattern, along with muscular hypertrophy in the classic so-called onion skinning appearance. And then in glomeruli, you get double contours. It can look just like NPGM. And you get ischemic capillary wall wrinkling, you can get secondary segmental sclerosis, and there may be hypercellularity when there's resolving injury from mesangiolisis. So here is still some activity. Oops, you can of course get chronic and, okay, what did I do? Okay. Here there's still activity. Of course you can have a chronic active lesion. And here we're getting this fibrosis, but you see it's in this sort of circumferential pattern, and this is just a classic image. It's what used to be called a glomeruloid body for people who are over 60. And because it actually is the same size as a glomerulus, even though, believe it or not, this was an arteriole, and it has this rounded sort of look like a glomerulus, so they were called glomeruloid bodies, but this is all chronic changes of thrombotic microangiopathy. And here is advanced ischemic glomerular capillary wall wrinkling with obliteration of the capillary lumens. Why is this not collapsing glomerulopathy? Because there's no podocyte hypertrophy and hyperplasia. This is an ischemic picture. And then here's ischemic segmental obliteration and sclerosis. And here in chronic thrombotic microangiopathy, it can look just like NPGM, where there's this lobular, many double contours. And here we see double contours. There can be mesangial interposition, but another way we can get double contours is this pale, fluffy stuff is actually deposition of altered fibrin and some subendothelial edema, it's been described as. And then the endothelial cell makes new basement membrane material, which you can see right here, so we get a double contour. So we don't necessarily need mesangial interposition. The endothelial cell can do this alone, which happens in thrombotic microangiopathy and also in transplant glomerulopathy, but there can also be mesangial interposition. So what is the differential diagnosis of thrombotic microangiopathy? Again, it's just a pattern of injury. Well, there's 2 different ways to think about this. One is it can be hemolytic uremic syndrome, or HUS, which can be infectious. The classic Shiga toxin, right, the classic go eat a Jack in the Box and then end up with HUS. For those who are, again, a little older. Atypical, or I guess the more recent one is spinach. It can be atypical or complement mediated, which is how it relates to C3GN, or it can be secondary due to drugs, bone marrow transplant, other infections, pregnancy, etc. And then there's TTP, antiphospholipid syndrome, scleroderma renal crisis, immune complex lupus vasculopathy, and malignant hypertension. These are all forms of morphologic thrombotic microangiopathy. But another way to think about it is looking at it as primary versus secondary versus infection. So in primary thrombotic microangiopathy, it can be acquired due to autoantibodies, which may be against complement causing HUS or Adams-13 causing TTP. It can be inherited, again, mutations against complement factors causing HUS, coagulation factors like DGK epsilon causing HUS, Adams-13 causing TTP, and these, again, require an additional trigger to make the disease happen and then not resolve. And then secondary, which all of these, malignant hypertension, drugs, radiation, bone marrow, these can be thought of as either secondary TMA or HUS. And then autoimmune would be the immune complex lupus vasculopathy, glomerular associated, then infectious, your classic STEC or HIV or other infections. So it kind of depends how you think about it. But the bottom line is there's a lot of different things that can cause TMA. So the morphology is not specific for a specific etiology, or it's not diagnostic for a specific etiology, but there are clues. Again, even if there are clues, there's still a differential, and it's up to the clinicians to go back and do the antiphospholipid workup and check the Adams-13 activity level and do all of that to find out what the underlying disease is. But when there's only small vessel involvement, glomerular capillaries and arterioles, it's more likely to be HUS or TTP. HUS can have more vascular wall injury. TTP can have more platelet-rich thrombi. Seeing only small vessel disease is somewhat suggestive of HUS and TTP. This vascular wall injury and platelet-rich thrombi are extremely soft diagnostic tools. Larger vessel involvement tends to be more malignant hypertension and scleroderma, but again, you can't hang your hat on that. And of course, antiphospholipid syndrome can involve any size vessel. So those are all always in the differential diagnosis. Cortical necrosis is usually HUS. It can be pregnancy related or HUS of other causes, but that's usually HUS. So what about atypical HUS, which is the complement-mediated thrombotic microangiopathy? Well, it's rare. It's even more rare than C3GN. And it's got about twice the incidence in children as in adults, which makes it still exceedingly rare. But we do see it, certainly, on biopsy. And again, it's due to alternative complement pathway dysregulation with complement activation on the endothelium. So in C3GN, you have fluid phase complement dysregulation. In thrombotic microangiopathy, you have tissue phase. So that's one of the reasons you can have these different manifestations of complement dysregulation, in addition to the specific abnormality. Again, there's a triggering event. It's more often viral in HUS and somewhat more often bacterial in C3GN, but again, not always. And interestingly, someone might say, well, why is there renal failure? Well, the renal failure can be due to ischemia, but the hemoglobinuria itself may damage tubular epithelium and cause an elevated serum creatinine level. So if we look at the alternative complement pathway dysregulation and we look at the genes, genetic causes overall are thought to account for more than 60% of cases of atypical HUS. Although depending on the study, of course, it varies. And most often it's due to factor H, and then less often MCP or membrane cofactor protein or factor I, and on down, as you can see here. And factor H autoantibodies overall are thought to cause about 6 to 10% of cases of atypical HUS, although there was one study in India where in children they found it as a cause of up to 56% of the cases, but that was really an outlier. So C3GN and thrombotic microangiopathy, or atypical HUS, can overlap, which is no surprise, given that they both have an underlying similar pathogenetic mechanism. And this is actually from a case I had of an adult male who had a recent viral infection and then presented with anemia, hypocomplementemia with a low C3, normal C4, and a creatinine of 2.6. And on biopsy, he has thrombotic microangiopathy with thrombosis of an arteriole, some glomerular capillaries, but there also is a little bit of mesangial widening. There's some silver negative stuff right here in that mesangial region. By immunofluorescence, typical C3 with both mesangial and some irregular granular staining, as well as fibrin in the vessels, of course, corresponding to the thrombotic microangiopathy, and by EM, large electron-dense deposits, subendothelial mesangial, corresponding to the C3. So this is a patient who's presenting with both manifestations of C3 dysregulation, or complement alternative pathway dysregulation. So these clinical manifestations relate to the underlying triggering event. They can relate to the specific mutation as well as the number of abnormal genes. So many of these patients will have mutations in more than one gene, as I've mentioned, or have mutations plus autoantibodies. Whether it's in the fluid phase versus the tissue phase or both. And then the site and intensity of the dysregulation of the complement pathway. So what about in transplantation? Well, recurrent HUS occurs. It's pretty uncommon because HUS itself, atypical HUS, is pretty uncommon. But when it does recur, when you do have atypical HUS, it recurs about 60%, again, depending on the underlying specific complement lesion. Other forms of recurrent thrombotic microangiopathy include antiphospholipid syndrome, TTP, and autoimmune disease. But having de novo thrombotic microangiopathy is much more common than recurrent disease. And the most common cause is probably drugs. Calcineurin inhibitors and the mTOR inhibitors can cause thrombotic microangiopathy. You may have antibody-mediated rejection with associated thrombotic microangiopathy. And in that case, the thrombotic microangiopathy may be due to endothelial damage from the antibody. But some of these patients do have underlying complement dysregulation that was never identified before transplant. And when you look at them, a certain percentage of them will have abnormalities, have underlying mutations that then are triggered by this antibody-mediated reduction, and they'll develop a thrombotic microangiopathy. There are a few reports of patients who had C3GN in their native kidney, and then they developed thrombotic microangiopathy in the transplant kidney. So again, depending on different factors, whether there's underlying endothelial injury in the transplant, it may manifest in a different way. Or it's possible the patient had an underlying primary thrombotic microangiopathy that wasn't recognized. How many times do you get a transplant biopsy and the primary disease was hypertension or diabetes? In other words, we didn't transplant the kidney, we have no idea. This patient happens to be hypertensive, as is every patient with end-stage kidney disease. So most of the time we really don't know what the primary disease was. So morphology, again, is not diagnostic for a specific entity. So if we look again in the transplant setting at recurrent HUS, atypical HUS, again, the most common mutation is factor H, as in primary native kidney, atypical HUS. All of them have been shown to be involved with recurrent thrombotic microangiopathy, and there's two of them I don't understand. And maybe somebody here can explain this to me. If we look at MCP, membrane cofactor protein, this is a membrane-bound protein. So if you put in a kidney transplant, that kidney should have no abnormality in the transplant. So why would you get recurrent disease when you have a membrane-bound complement dysregulatory gene, which now is normal? So the only thing I can think of is maybe there was chimerism, and that now you have some abnormal proteins that are there because of the chimerism. But I don't understand why membrane, it's the same with thrombomodulin, why a membrane-bound protein would have a recurrent disease. That's like, you can't have recurrent Alport syndrome because the new kidney you put in doesn't have the abnormality. So I find that to be a very interesting finding that I think would be fun to look at and try and understand a little bit better. So the bottom line is thrombotic microangiopathy and C3 glomerulonephritis are distinct but related disorders. They can occur simultaneously. They can transform one to the other depending on the complement dysregulation and the host factor, the patient factors. The complement interactions are extremely complex. We really don't understand from the alternative complement pathway, how do they relate to the classical and mannose-binding lectin pathways? Is there crosstalk? Can you have C3 convertases from both? And you really need, as with all renal pathology, clinical, pathologic, and in this case, genetic correlation to understand these diseases. Because if you have a certain complement dysregulation, you may treat with eculizumab. If you have a different abnormality causing this disease, you may not. If it's an underlying paraprotein, you're going to treat the paraprotein. You're not going to treat the complement disorder. So it's very important to put all these pieces together, and I think we're just at the beginning of understanding this story. And that's it. Thank you.
Any questions, Dr. Nast?
Yeah.
That was a great talk. I want to ask you about DGK epsilon function.
Yeah.
So the original description by Pathology just said NPGM, and I think Leptin described the association with TMA. But I think this was probably before C3GM was recognized as an entity. Have those biopsies been looked at again to see whether they actually have C3GM?
I don't know about those, but DGKE is a cause of C3G. The thrombomodulin only is related to HUS, but DGK epsilon has been associated with not only with C3G but with dense deposit disease as well, so with the C3 glomerulopathies. And that's, that inhibits the phosphate, that whole pathway. And so we don't really understand exactly how it works. It used to be thought it was through the clotting system, but it probably isn't really. But yeah, both, actually all of them, HUS, atypical HUS, C3G, and DDD, have all been related to DGK epsilon. But I don't understand how. So, yeah.
The current recommendation, the fuzzy one, so-called 2+ more than magnitude. Now that's by IF, by the ITIS lab. Many labs are using immunoperoxidase. What do you tell them?
I don't like immunoperoxidase. We don't use it. I don't think it's reliable, particularly for the complements. I don't know how they do it in Australia, which they only do it by IP. We do IF, and I really don't understand even how to interpret the immunoperoxidase because I find the background difficult, so I have no experience with that. And if they have formalin fixed tissue, they could do IF because you can do it, except it actually doesn't work for C3 on the pronase digested. But I can't answer that because we don't use it, and I've looked at some of them. I find them confusing. So my advice would be switch to IF.
The chronic TMA. That fluffy stuff is already.
Yeah.
You mentioned there are fibrin, also fibrin. Is it known that it is?
Well, when you stain for fibrin, you find staining in that area, even when there's no fibrin tactoids or anything else. And there's probably fibrin breakdown products that are in there. And there's been staining done looking for fibrin breakdown products, and you can identify them in there. So they don't look like tactoids. And then you get an endothelial reaction. There's so-called edema. I don't understand the edema. I don't think it's edema. I think it's sort of an I'm not sure exactly what's in there. There's some mucoid substances in there, but there is some altered fibrin in there. Exactly how it's altered, I don't know.
Staining for fibrin, if I go check my antibody, I've never seen.
Oh, we see, no, it always stains for fibrin in our lab. We always, when you have this, you get beautiful linear, it's linear staining. If you go back and look at your glomeruli, you will find beautiful linear staining along the capillary walls in these lesions, just like pseudolinear staining, say, in a diabetic for IgG and albumin. And if you look at your cases of thrombotic transplant glomerulopathy, you'll find beautiful linear staining for fibrin that associates with that subendothelial material.
Anyway, in that case that had a dual C3GN and TMS,
Yeah,
how old was the patient?
that was an adult.
Adult. Have you looked for a monoclonal gammopathy?
Yes.
Was it negative?
No monoclonal gammopathy.
No.
No, we look for that in all adults with C3GN. Yeah. No, you can get these overlaps. I mean, it may happen more often in kids, but that was an adult patient. Yeah.
I have a question. So I'm a transfusion doc, so we've seen a lot of these cases come through historically, and they've gotten treated with plasma exchange, not for the Histopathology HOS, but for many of the others. And there's a transition now in the treatment field to move from plasma exchange to eculizumab. So I was wondering if that eculizumab picture is changing sort of the spectrum of like diagnosis, or how does it diagnose it, or if there's anything that like should suggest more upfront eculizumab. I know most guidelines are moving to take eculizumab, and if that doesn't work, that plasma exchange.
Yeah. So first of all, I'm a pathologist. So.
But is it changing like how
No, it really isn't.
on the diagnosis?
It doesn't, because first of all, they usually would do a biopsy before they would give eculizumab. For one thing, an insurance company won't pay for it if you don't have really hard evidence that they need it, because it's what, $100,000 a pop. So so we usually get the biopsies first, and often it doesn't work. So it's not the be-all and the end-all. There's a couple of other interesting complement drugs that are in the pipeline. There's the C5a receptor inhibitor, and there's also a factor D inhibitor. So these may be better, cheaper, alternatives. So I don't know if eculizumab's days are numbered. But there have been studies certainly showing that even when the patients clinically get better, they still have the morphologic changes. There was a paper from the Columbia group that showed that. So we don't usually see them after they're treated, because they already have a diagnosis, so they don't get repeat biopsies. But we haven't noticed any change in the morphology.
Actually, what is it talking about?
Well, these complement-mediated thrombotic microangiopathies, the atypical HOS, they've been historically treated with plasma exchange, kind of lumped in, treated based on TTP.
Yeah, which doesn't work usually.
Yeah, but now there's movement to eculizumab.
Well, yeah, and I can tell you in the transplant field, when these patients get thrombotic microangiopathy, they'll just throw eculizumab at them right away. And sometimes it works, and sometimes it doesn't. So.
Is there some way to tell that's where the question is, who's going to work?
Well, I think you'd have to know what the underlying complement problem is, to know if it's going to work or not. So really, it would require working up, looking for autoantibodies, looking at the genetics and so on. And sometimes when they really think it's mediated by the antibody and the antibody-mediated rejection, and they don't think there's a complement problem, it still works sometimes, because it's the driver is different, but you have that antibody constantly there. So even though you may have normal complement function, you have a driver that's constantly there. The obvious answer is to get rid of the antibody, but good luck with that. That's not. That once they're there, it's hard to get rid of them.
In general, pediatrics, our experience has been in atypical HOS complement.
Right.
Eculizumab works fairly well. Whether you want the additional stuff or not, that depends. If it's an antibody, of course, you have to get rid of the antibody.
Right. We're talking about transplants. Yeah. So let me ask you a question.
However, in C3 glomerulopathy,
doesn't work so well.
In general,
doesn't.
work. Right.
Even when it works, you don't know.
You don't know. If it's an antibody, of course, you have to get rid of the antibody. But if it's which patient?
Yeah. So, but let me ask you about atypical HUS, because when you treat them with eculizumab, sometimes you have to continue treating. But in some of them, if they had a mutation that's not as severe, you can get them to a point where they re-regulate their complement, and then you can stop the drug. And actually, in plasma exchange, why sometimes that might work, because if it's an autoantibody against factor H, then of course your plasma exchange is going to work. And then you might want to give them Rituxan or something to prevent the autoantibody from coming back. So again, it's really important to know what it is, not only in terms of is it autoantibody or is it a mutation, but as we learn more, which mutation, because some mutations you may only have to give a short course and some you may have to give longer term treatment, right? Depending on how severe it is.
But as
So.
a clinician, as far as I'm concerned, at the moment, the distinction between DDD and C3GN, essentially there's none, other than
Right.
other than ultrastructure.
Right. The only thing will be, are they driven by different mutations, and that might reflect on different approaches, you know, hitting the complement pathway in different places. But you're absolutely right. It's a spectrum. And one of the reasons to separate them is to understand if there's a difference. If you lump them together, you'll never know that. But you're absolutely right. Clinically, they really are. The only difference is DDD does tend to recur more in the transplant than C3G. It virtually has 100% recurrence, suggesting maybe it's a worse lesion. You know, I don't know. Okay, thank you.